Sure. The KEYNOTE-048 trial was designed to investigate whether the addition of an immune checkpoint inhibitor, pembrolizumab, could improve results in the first-line recurrent metastatic setting for head and neck squamous cell carcinoma. So the trial was designed to compare two pembrolizumab-containing regimens to the extreme, which has been the standard for about over 10 years. So the control arm was platinum 5-FU with cetuximab, and the two experimental arms were pembrolizumab monotherapy and pembrolizumab combined with platinum 5-FU chemotherapy. So this trial looked at three populations partly based on PD-L1 expression. So we looked at PD-L1 expression based on what was called the combined positive score, which looks at expression of PD-L1 in tumour and immune cells. And so we had groups based on the PD-L1 expression of what was called CPS greater than 20, greater than 1, and the third population was the total population. So if we look first at the results with pembrolizumab monotherapy compared to the extreme regimen, pembrolizumab actually improved overall survival in the CPS greater than 20 and in the CPS greater than 1 population. So those two populations represent together about 85% of the patients in the trial. In the total population, the pembrolizumab monotherapy was non-inferior, but it wasn't shown to be superior. The response rate with pembrolizumab is lower than with the extreme regimen, but the responses are substantially longer, and the toxicity profile is favourable with significantly less adverse events with pembrolizumab monotherapy compared to the extreme regimen. If we turn now to the comparison between pembrolizumab chemotherapy to the extreme regimen. This regimen actually improved overall survival in all the populations that we looked at. So in the total population and also in the population with the PD-L1 CPS score greater than 20 and greater than 1. It wasn't associated with any significant difference in progression-free survival. Response rates were similar, and the adverse events in terms of absolute numbers of severe events and discontinuations due to treatment were actually very similar. So I think the first thing to say is that the pembrolizumab, whether used alone or in combination, will become the standard of care and change their treatment paradigms for recurrent metastatic head and neck cancer. I think for the patients that have particularly the CPS greater than 20, pembrolizumab monotherapy will be a very reasonable option. For the patients with CPS between 1 and 20, I think they're both reasonable options, and considerations may relate to rate of progression. In patients that have more rapidly progressive disease, one may, irrespective of PD-L1 expression, one may err on the side of giving chemotherapy plus pembrolizumab. I think for the 15% or so of the population that are PD-L1 negative, one wouldn't at this point, based on the data we have available at the moment, recommend pembrolizumab monotherapy, but probably the combination of pembrolizumab and chemotherapy. So there'll be some clinical factors as well as PD-L1 expression that will come into the decision about whether to use monotherapy or the combination. So this is an important step forward in improving survival, but there's still plenty of room for improvement. We need to understand a little bit more about the relative monotherapy versus the combination in the different subgroups, and hopefully more data will emerge over time. I think it also opens up the possibility now of building on the pembrolizumab backbone, particularly the monotherapy with other immuno-oncology drugs, to see if one can further improve the results in the subgroup where monotherapy actually seems to be particularly effective. The other thing that's clearly occurring is we're looking at the role of pembrolizumab and immune checkpoint inhibitors in general in earlier stages of disease, and trials have already been conducted and no results available yet, incorporating it into early stages of disease such as locally advanced disease, neoadjuvant prior to surgery. So I think that's what we will see. It will become entrenched as part of standard treatment for recurrent metastatic disease, but there may be opportunities in the future for it to become used in earlier stages of disease.